Good afternoon and welcome to Union Community Health Center's Grand Round Series. Today we have the pleasure of having Dr. Sherwin Su, who is attending orthopedic surgeon in the Department of Orthopedic Surgery at St. Barnabas Hospital Health System. Today he'll be talking about robotics and total joint replacement.
Good afternoon, everyone. We are very excited today to have our special guest, Dr. Sherwin Su, who is our attending physician at the Department of Orthopedic Surgery. So he's one of our new orthopedic surgeons that will be starting at Union. So we're really excited to hear his talk about robotics and total joint replacement. And he's a attending physician at St. Barnabas Health System, and he'll be doing half a session or a session here, right? Also,
yeah. Basically, him and Dr. Bavaro are going to alternate Monday PM sessions.
Oh, fantastic!
Yeah,
great. So we're happy to have you on board, Dr. Su.
All right, thank you all for having me. My name is Dr. Sherwin Su. I actually will officially be starting at St. Barnabas Hospital next week, so be pretty fresh. I'd like to also thank Dr. Salcedo, Dr. An for giving me this opportunity to give this talk and also to be able to meet you guys in person as well. So the title of this talk is going to be Robotics and Total Joint Replacements. My background is such that I did orthopedic surgery residency at Seton Hall in Jersey at St. Joseph's in Patterson. And then I did fellowship training in total hip and total knee replacements at Hospital for Special Surgery. So I think some of you guys are familiar with one of our other providers, Dr. Naveen Signamala. From what I understand, he came to Union for at least a year and a half. He usually came on Monday in the afternoon, and he's very thankful for the referrals that you guys sent to him. And he was able to do, several cases, from that. Unfortunately, Dr. Signamala, he kind of made a career shift, so he is more per diem at St. Barnabas Hospital, so he won't be able to come to Union anymore. But myself and Dr. Bavaro, we're looking to continue those sessions on Monday. So it'll be Monday afternoon, and we're still in the process of credentialing. So hopefully that's going to kind of take effect sometime in June. Okay, but we'll also give our kind of contact information. We also have a scheduling coordinator that I'll give information on later on. So like if you want to set up patients to see at Barnabas or, hopefully eventually at Union, we'll be able to do so. So I just wanted to, even though the talk is basically robotics and total joint replacement, I also just wanted to go through some of my thinking, with osteoarthritis treatment options, as well as kind of the lead up into surgery, because this is something that, I'm sure you guys deal with as well. So as we all know, osteoarthritis is degeneration of the joint cartilage and underlying bone, most commonly of the hip and knee. Of course, other joints can be affected. After that, I would say is probably the shoulder and hand. And this typically presents in ages of 50 years and up. I would say most commonly the age in which patients that require surgery will be somewhere in their 60s, but in some cases where they're kind of more active patients or they might have history of arthritis, that can be in ages 50 or even below. And unfortunately, this is a chronic progressive disease. Basically that cartilage which coats the bone, once it's gone, it doesn't regenerate or come back. So there are some things that you can do that we'll kind of go over that will help with some of the symptoms. But depending on how it gets controlled, then unfortunately sometimes the patients either have to live with it, they have to modify their activity, or we have to kind of try some different measures. And if those measures fail, then sometimes they might require a total joint replacement. So on physical exam, classically, there can be swelling, limited range of motion, as well as crepitus. In hip, in terms of signs and symptoms, this classically presents in the anterior groin. So if patients are kind of pointing towards their kind of like proximal thigh or their groin area, that's a good sign of osteoarthritis. For the knee, this classically presents in the medial or inner compartment of the knee, sometimes with radiation to the back of the knee. And also sometimes what it involves is the kneecap or the patellofemoral joint. In terms of a workup, as orthopedists, we always like to have some kind of X-ray films, before we see the patient. Ideally, prior to the consultation. But in Union, we will have X-ray available, but they're only available during certain times. But usually the views that we want to get is a weight-bearing view of the pelvis for the hips and a weight-bearing view of the knee for views. And this is something that, we can maybe work with the kind of radiology and IT people, in which maybe we can come up with an order set so that we can make sure that you order the appropriate films. But that being said, if not, then we'll be able to, get it done at Union. So this is an example of a, pelvis view looking at the right hip. This is AP. So this is the patient standing and kind of facing yourself. So this is the right hip over here. So this is an arthritic hip. You can see there's loss of the joint space over here. There's kind of loss of that smooth contour. So you kind of see flattening of the surface of the femoral head. And other signs that you can see is that you can see multiple cysts in the subchondral bone of the femoral head and acetabulum. And also you see that there's kind of a prominent bony spurs or osteophytes here, which can cause pain with impingement and also can limit the range of motion. And that you can also, the reason I like to get a pelvis is because you can compare it to the contralateral side. For the knee, we get 4 views. Classically, it's only 2 or 3 views, but we like to get some additional views that give us a little bit more information of the joint. So again, this is the AP view. So the patient is kind of standing and facing you. This is the right knee over here. And then over in this area, this is the medial joint space, or the inner aspect of the knee. And you see that inner compared to the outer aspect of the knee, you do see some joint space narrowing, and you see some basically a degeneration of the articular surface over here. But when we look at some other views right here, this is the PA view, kind of looking through the back. So this is the patient kind of facing away from you. You'll see the right knee over here, and you look at the inner aspect of the joint, and you see how that joint space really closes down. So when we get these views, it really kind of gives a complete picture. And of course, we also get the other views, which include like the lateral view over here, and also a sunrise, which looks at the kneecap. So again, I said that we'll kind of work and see if we're able to kind of make some appropriate order sets for that. But one thing I would also mention is that, sometimes the picture isn't all straightforward. So sometimes in some people, you can consider getting additional films. For hip pain, sometimes people may have a presentation of sciatica, and that people typically complain of kind of pain in their posterior buttock back there. So in patients like that, you're not sure, or you just want to get it for completeness, you can get a pelvis and get a lumbar 2 views. And similarly for the knee, sometimes you can have cases of referred hip pain that actually transfer to the knee, especially on the inner part. So sometimes for knee, you can also get the knee and the pelvis view. But that being said, we're happy with whatever films the patient comes in, and we can kind of get additional films, when we see them. But this is an example of, AP and lateral films of the lumbar spine. So this is in very extensive degenerative, disease over here on the lateral view. You have decreased in the this space over here and multiple osteophytes up front. Up front right here. And if you look down below at the hip, you can see that there's a joint space narrowing over here. So this patient has, both. He has arthritic hip and multiple degenerative disease of the spine. In terms of treatment options, so it has been shown by our Academy guidelines that physical therapy and weight loss are things that can be effective for managing some of the symptoms. I'm sure many of you prescribe physical therapy as well. The number that we kind of use, kind of for insurance purposes, usually we like them to try to complete 12 sessions if possible, and that's over a period of 6 weeks. Sometimes during these kind of encounters, it comes up the possibility of, whether you want to use a walking aid such as a cane. Most people don't want to use something like that, but it can be very effective in shifting the weight to the contralateral side, or you can use some supportive braces as well. And in most cases, I would say physical therapy is beneficial, but in some cases where it's very severe, it actually can exacerbate symptoms. And if it does exacerbate symptoms, either they have to modify, do some other activities at physical therapy, or in some cases, it's okay to stop. And then we will kind of document in our notes that, that's one reason that they had to stop, and that can help justify surgery in some cases. In terms of weight loss, I mean, it's easier said than done, but for every pound that you lose, you take 4 to 5 pounds off of the joint. So if you did lose 10 pounds, you're potentially taking potentially taking 50 pounds off the joint. Sometimes patients will ask, kind of what activities can they do, and it may sound obvious, but it is okay to walk. Just walk within what their tolerances are, because they might be afraid that they're doing kind of more damage that way. But other like activities such as stationary bike, or biking in general, or like elliptical and some activities at the gym, is perfectly acceptable. You're not doing more harm with that. And I put in here, the GLP-1 and GIP agonists. So this is a very hot topic, with Ozempic. I mean, perhaps some of you guys prescribe that to your patients. They can be very effective. But we also have our own kind of bariatric program where, in addition to surgery, they also can manage things pharmacologically, and they can also have a nutritionist as well. So we have those resources as well. In terms of medications, we all know about, acetaminophen and NSAIDs. These are kind of the dosings that I put down over here. I'm sure some of you guys are familiar with diclofenac or Voltaren topical gel. This is usually very well tolerated, because there can be some patients, they don't want to take pills, but, the idea of having a gel is more appealing for them. But not only that, it is kind of fitting for other patients that may have like renal disease, or they're on like Eliquis for anticoagulation. So it can be very safe for them. And then down here on this second one, these are kind of prescription doses of medicines that I would give. Probably the most common that I would give meloxicam, 15 milligrams. I usually give meloxicam because I feel that it's, very similar to Celebrex 200, which can be sometimes difficult to get for insurance reasons. And below here, the ibuprofen and naproxen, those are typically the doses that I would, prescribe for them. But I do caution the patients that, they do have to, watch a little more regarding a GI upset. And then down here with the tramadol. So tramadol to me is not like a first-line medication. This is a medication that I don't want on them long-term. But if patient's having exacerbation of pain, and maybe they're waiting for an injection or some medication to kick in, sometimes I might give them like a limited supply. But ideally, we don't want to have patients on some form of narcotic before the surgery. So in terms of what we can do for them in the office, we can do injections, especially for the knees. Cortisone injection is something you guys probably have heard. Maybe some of you guys give cortisone injections as well. But for me, this is probably the most bang for its buck. It can usually be effective very quickly, usually within like 2 to 3 days. And in some cases, it can last, a couple months. And you can see here in the picture, it is kind of like a white substance, usually like Kenalog or some other material. But if patients told you that they got injected previously with some white substance, usually that's going to be a cortisone injection. But this is something that we can give every 3 to 4 months as needed. I mean, if it's very effective, 3 to 4 months, they still feeling great, then usually I would just let it ride and I wouldn't repeat the injection at that time. For a hip injection, that is something that you can also do a cortisone injection, but that's something we'd actually have to refer out, because for the hip, it's kind of like a more precise target. So it usually has to be done under ultrasound or fluoroscopic guidance. So that's something that we could set up as well. And in terms of cortisone injections, these are usually well tolerated, but in some individuals, very rarely in some dark-skinned individual that you notice, so you can potentially get temporary hypopigmentation, which does eventually go away. And in patients that are diabetic, you may get a transient rise in blood sugar, although that's usually over a couple of days, but once in a while you can hear some patients say that it's affected them for longer. The other injection that we offer for arthritis is something called a viscosupplementation injection. So the material that is injected is something called hyaluronic acid. And this is something that isn't exactly cartilage, but it's part of the cartilage complex that surrounds the joints. And some of you have heard of it as kind of like a hyaluronic acid series, in which you might do like one injection once a week for like 3 weeks. Or what I prefer is that there's a single shot injection you can do. And from what I heard, that we can get this one here called Synvis 1, and colloquially that's known as a gel injection. So that's something that kind of works in a different way, and we do have it available mainly for Medicare, which is like a buy and bill model. In terms of this type of injection, it's usually not my first injection I would inject with, because the reason being is that it usually doesn't work right away. For this injection to work, it usually actually takes 3 to 4 weeks for it to get maximum effectiveness. So I usually will do a cortisone injection first, and then if you're open for it, then I could give the gel injection like a week or 2 later, depending on how their symptoms are. And this is approved for the knee, and you can do it up to every 6 months. For the hip, it's a little trickier because it wouldn't be covered by insurance. So in terms of, total joint replacement, obviously this is when, conservative measures fail. Your patients will tell you that, I've been having more bad days than good. It limits their daily activity. And these are some of the questions that we ask the patient. We ask them, how many blocks can they walk? Do they use a cane, any braces or anything to help them get around? Do they take any medications? Do they have any trouble putting on clothes or, putting on their shoes? Finally, we kind of want to see the response to these conservative measures. So very rarely, unless the patient has been seeing people and kind of gone through the ringer, would I indicate someone for surgery right away, unless this is something that they've been thinking about for a while. So I'd like to see their response to these conservative measures. And that's something that can happen, gradually over time, or sometimes it can actually happen very quickly, where just like the injection that was effective previously is not effective before. So in terms of total joint replacement, so this is, we're going to get into a little bit, but this is with total joint replacements, basically we're kind of resurfacing the articular surface. So for the hip over here, we're going to replace the socket and the femoral head. So it's metal, and then in between there's plastic and the ceramic head. And then for the knee over here, we're resurfacing basically the femoral condyles and the tibial plateau. So metal, and then plastic in between as well. So one other thing I wanted to mention to you guys is in terms of medical optimization. So this, goes into modifiable risk factors, prior to surgery. So these are things that you deal with, but these are things that we pay attention to, prior to surgery. One of which is dental work. The thought is that with, poor dental hygiene, the bacteria can, go into the bloodstream, and there's a risk of hematogenous infection, and it can go to where you do the surgery. And when that happens, that's something called a periprosthetic infection. And unfortunately, that can be not an easy problem to deal with. In some cases where it's persistent, you actually have to do two surgeries, one in which you remove all the metal and put some antibiotic cement in there, and another surgery when you implant the metal again. And that's something where it's like a huge kind of burden, on the patient, not just, in terms of stress to their body, but also just in terms of recovery as well. So things like that, we try to, mitigate that risk if we can. So in terms of dental work, patient needs to get some, cavities or kind of teeth pulled prior to surgery. We usually would recommend a dental evaluation. We also have our own clinic at Barnabas. And then after surgery, we usually don't recommend any dental work for at least 3 to 4 months, but it's kind of attending dependent. In terms of diabetes, so we all know that, people with diabetes are at increased risk of infection, but in terms of surgery, they're at increased risk of wound issues as well as periprosthetic infection, which we try to avoid. But the goal that we try to meet would be like the A1C of less than 7.5 or 8.0. Just so that we can, kind of mitigate that complication. In terms of obesity, it has been shown that BMI greater than 40 is increased risk of postoperative complications. So this, of course, affects, wound issues and periprosthetic infection. But the other things that it can affect would be also like the longevity of the implants as well, because you're putting more stress on these implants, they're not going to last you as long. Sometimes you might hear from patients like, well, this weight because I can't move around, I have my arthritis. So, they're thinking that, if they get the surgery, that's kind of their gateway to losing weight. But unfortunately, they've done a couple studies with, these patients and following total joint surgery. And, unfortunately, like their weight loss following surgery is either very little or very modest, so you're not going to get a very big change following the surgery. So this is something in which, like referral to kind of bariatric or doing some kind of lifestyle changes, hopefully can, get them down to a less risky surgery group. In terms of smoking, of course, we know smoking is bad, and in general, we would recommend a smoking cessation program for at least 4 weeks. People will vary in terms of what they would accept. I think at the very least they need to reduce the amount of smoking, but if they're kind of still smoking a pack a day, of course, that's not ideal for surgery, and it markedly increases the risk for infection. In terms of other factors, so these are factors that aren't necessarily like well studied, but I mean, these are like sometimes when you see a patient whether they're going to do well or not. And in these cases, in my opinion, patients that are very self-motivated or have good family support, these are the patients that do the best. In terms of motivation, what I would say that these patients are willing to kind of put in the work and to get better. and they also may have some goals in mind. They can be simple goals, rather they just want to walk further, or they want to kind of go to the gym or just play with their grandkids. But these are patients, when they are very self-motivated, they tend to do the best. And likewise with family support, that's an important factor, and not just like after the surgery in terms of helping them, after they had this big procedure, but in terms of just kind of keeping them, their goals in mind. On the other side of the spectrum, these are actually risk factors that have been well studied. So, these patients actually do not do as well, or their kind of surgical and post-operative course may be more unpredictable. So that does include like chronic narcotic use as well as psychiatric disease. So chronic narcotic use, that's something that is very, very tricky. I mean, something like that, we do have inpatient pain management, but like even more important is how their pain management is going to be as an outpatient, so you have to make sure that there are kind of people on board there. But if you have a patient that has maybe other kind of pain factors in addition to their arthritis, I think chances are like trying to get them off the narcotics after surgery is going to be very, very difficult. And the other thing is that, they may not do as well, it's because if you do a knee replacement and the patient is not able to get the pain adequately under control, then one of the complications they can get stiffness, in which the knee doesn't bend as much. In terms of psychiatric disease, we're kind of more looking at major depressive disorder, bipolar, and schizophrenia. Anxiety that's well controlled usually isn't a factor. I know maybe some of you guys maybe do the screening for depression. There's maybe different ones you can do, but it has been shown with the PHQ of 10 or above, they're at increased risk of major depressive disorder, and they don't do as predictably well. So in terms of preoperative clearance, so this is something where I don't need to tell you guys about. I'm sure you guys are all familiar, but medical clearance, usually we do it within 30 days of the scheduled surgery date. Cardiac clearance is indicated. Labs, we usually request, and that does include PT, PTT, INR, and then usually we need an EKG chest X-ray within 6 months. Other things that I noticed have come up during preoperative clearance. One is the presence of UTI or asymptomatic bacteriuria. That by itself is not a contraindication to surgery. That patient can just do a course of antibiotics and can continue it through their hospital course if needed. But the one thing I did want to mention, and this is either whether you guys do injections yourself or whether I was to give an injection, we actually do not recommend surgery within 3 months of injection. And the reason being is that it has been shown in some registry studies that there is actually a double risk of periprosthetic infection, which I mentioned is a complication we want to avoid. So whenever I give patients a injection, I tell them, I give them a date. So if we did it right now, kind of mid-May, we wouldn't potentially be able to do surgery until August 15th. So if the injection works, that's great, but otherwise we might have to wait a little longer, and I'd probably follow them up within 4 to 6 weeks to see how they're doing. So in terms of when we schedule the surgery, kind of how we have things set up, we're working on getting a total joint class. So that's something that the patient would and their family would attend prior to the surgery, so they can get an idea what to expect. And some patients that are very healthy, this potentially could be a same-day surgery. So they go home the same day. These are, of course, going to be kind of patients that are healthy, or very low comorbidities, but the ages would be probably like the low 60s or like in their 50s. But another part of that is important is that they have to have a good home situation and social support. Otherwise they're not going to do well. In those patients, potentially we could consider doing what's called a prehab session, which is basically like physical therapy, session that focuses on how to get around after the surgery before actually doing the surgery. For me, majority of the patients are admitted to the hospital. When they do have the surgery, they're usually under spinal anesthesia. They're discharged to home usually on post-operative day number 1 or 2. So if you do the surgery on Wednesday, then they're going to go home on Thursday or Friday. I actually would say the majority of the patients probably can go home the next day. And then we also do have some kind of DVT prophylaxis protocol. I mean, usually this is, everyone differs in terms of it, but my protocol is usually for 6 weeks total. And this is either a combination of full dose aspirin or some combination of Lovenox or Xarelto with aspirin given sequentially. In terms of the post-operative course, they can put weight on the operative extremity immediately after surgery. In fact, if we do the case, at a good time during the day, then we try to have physical therapy work with them basically like within an hour after the surgery, like once the spinal works off. And they can do limited stairs. So if a patient, has stairs to go up into the apartment or they're in a duplex or something like that, that's something where, they should be able to handle that after the surgery. And we do provide them with a walker at first, but if they're doing very well, they can switch to a cane within the first 2 weeks. In terms of driving, in order to drive, I think you have to be able to get in and out of the car safely. So this is something where it's really more like the 3 to 4 weeks out in which they're able to use a cane kind of more consistently. So in terms of postoperative course, we do have the patient do physical therapy. So they'll receive physical therapy in the hospital, but for the first 2 weeks, if we can get it approved by insurance, we usually have them do some home physical therapy. And if they can't get it approved by insurance, then we'll usually just do some home exercise. Then we'll do outpatient physical therapy. That usually starts during the 2nd or 3rd week postoperatively, and that's usually for 6 to 8 weeks, 2 to 3 times per week. And then usually in terms of back to activity without restriction, that's within 10 to 12 weeks. So that refers to basically walking unlimited distances. They don't need a cane or walker. They're done with the physical therapy. They can go back to whatever activities they want to try. So now comes to the second part of the talk, which is basically the robotics. So what is it and why do I bring it up? I guess the reason that I bring it up is actually because St. Barnabas, we are going to be acquiring a robot for total joint replacement. So this is something that is something that I'm very familiar with using, as well as Dr. Bavaro. So it's, I would say it's been more popular it's been around, I'd say, in this form for the past 8 to 10 years, and maybe more popular over the past 5, 6 years. And we'll kind of go into what some of the advantages are. But traditionally, with general surgery and robotics, some of you may be familiar with the Da Vinci machine. So Da Vinci machine is basically, the robot has multiple arms that you drape over the surgical site and is connected to a console that the surgeon will be at. And the surgeon can kind of manipulate certain controls, and by doing that, they can manipulate the arms of the surgery. So something like that is actually, in effect, is like an enhanced arthroscopy. There's small incisions in which these kind of robotic arms can go in there, and those arms can actually perform the surgery. They can dissect, they can cauterize, they can even throw sutures. And it's effectively the surgeon guides the robot to perform the surgery. When this first came out, it was kind of more with OB-GYN and like urologic procedures involving the pelvic floor. But nowadays, like most hospitals have a robot. So I think a lot of the general surgeons are using a robot as well. But this is in the general surgery Da Vinci system. For orthopedic surgery, this is kind of the system that we will be getting. This is called, the company is called Stryker. And then the system for robotics is called Mako. So it's a Stryker Mako system. So this basically robot is something that is kind of on the side of the surgical table, and then we bring it in for certain parts of the procedure. But this is a robotic arm, and you can have different tools on it. And one tool up here on the upper left, this is basically a saw that we use for either partial or total knee replacement. And the one down here, this is a reamer that we use for preparing the socket of the bone during total hip replacement. So a more accurate kind of term would be that this is robotic assisted surgery. So this is a robotic arm that has something called haptic guidance, which means that basically once the robot kind of knows that surgical area in the boundaries, it kind of keeps it within those boundaries. So when we're able to do that, we're able to precisely remove bone and place the surgical implants. And this is CT based. So like we do have the patient get a special type of CT prior to the surgery. And, of course, CT is good at looking at the bone, and this is a bony procedure, and it allows us to kind of plan the surgery in 3D. Unfortunately, it is the same surgical incision. So like it's not, I wouldn't say it's less invasive than traditional surgery. But the good thing is that we still are performing the surgery. So, we're still kind of holding the knife. We're putting retractors in there. We have assistants in there. And what I think of it is this is kind of like an enhanced navigation or an enhanced tool to carry out the surgery. So as I mentioned before, the advantages would be to precisely remove the bone and place the surgical implants. This allows us to have advanced pre-surgical planning. So before the surgery, we know exactly what we're going to put in there. But what also makes it equally powerful is that during the surgery, you can make adjustments, so you can make adjustments to that plan. This is an example. So that's the x-ray I had before of this patient with an arthritic hip on the right side right here. So this was just the standard weight-bearing preoperative film that we had. Traditionally, when we plan the surgery, we do something called templating. So the templating means to kind of predict the implants that we put in based on X-rays, which are in 2D. And you get a good picture of it, but with the robotic system, we can actually template in 3D. So like they actually are able to project an image of what the X-ray and what the implants are going to look like after the surgery. So in this particular patient, this is what they projected, what the implants would look like and be positioned. And this is the final post-operative images. So if you look at it and kind of go from this one to the last one, you can see it's very, very close. So it allows us to be very precise. So again, just kind of looking back, that's the predicted image right here. And then this is the actual one right here. Okay. And the thinking with this, and we'll kind of get into it, is that by kind of more precisely putting the implants where you want them to, you can hopefully get better range of motion and better longevity. But the thing is that in terms of looking towards longevity, that's something that we kind of need studies that are more 20, 30 years out versus 10 years out, which is the duration of this technology. So here I'm going to kind of have two short videos. This is for a total hip replacement. This kind of goes into more of the planning aspect of it. So let me see if this will play right here. This is kind of, this is not the right, it's kind of a little confusing. Let me see if I can play that again. Yeah, this is projecting sideways, okay, but essentially this is a coronal view of the bone right here, and then this kind of green right there, that's basically where we're going to place the implants like that. But you can kind of see how the structure is looking in 3D, so we can see exactly how we're going to place the cup there, how it's positioned, what the overhang of the implant, and this extra bone around here, that's basically both, these are kind of bone spurs that we have to remove during the surgery. So it's, again, as I said, it's a powerful tool being able to plan the surgery in 3D. This is a view just kind of looking at the femoral stem in terms of looking at the fit and where we're going to position it. But just kind of seeing in 3D, we can kind of see it at all angles, and it's definitely more accurate than having a 2D X-ray. So this is another a video. Let's see how it kind of projects. This is kind of looking at the kind of precision of the robotic arm, and this is one from one of my mentors at HSS, named Dr. Robotic. So let's see if this will play again. Okay, so this didn't flip, so that's good. So basically, you see, the robot's kind of on the side of the field, and then this is a robotic arm going in on the left over here. And you can see as they're kind of placing the robotic arm with the reamer on there, you can see on the right side, you basically get some real-time feedback. So you can see kind of what angle you're putting it in, and also like what bone that you're aiming to take away, and it's in real time. And what you'll see is that he's going to prepare the bone, so you actually see the bone fill up on the reamer over here. But while he does that, you're also going to see some feedback on the right side with the bone being removed. So right now, it's not what's going to happen in the next couple of seconds. That green is going to disappear as the bone is being removed. So this kind of allows for some real time feedback, and you can see here, yeah, the bone is being, it was being removed, sorry. But, this allows, it's a very powerful tool in terms of planning and executing the surgery. So I didn't include any videos for the knee, out of interest for time, but these are some examples I wanted to show, some cases I did robotically. So this is a patient that had a prior ACL reconstruction. So these are kind of some staples that are used for the graft that we used. Using the robotic surgery, you're able to kind of very precisely place these implants without having to remove the previous hardware over there. Because in some cases where you're removing the previous hardware, you can actually do more damage. So this was able to allow us to, kind of calculate which bone to remove and how to place these implants precisely. This is another example here. This is a patient where he had a prior surgery, but it wasn't at the knee, it was below the knee at the tibia. So he broke it in some kind of car accident. But if you're doing a traditional total knee replacement, we use instruments that have to go into the canal. But because this was displaced like so, you wouldn't be able to use that type of traditional instrumentation. So by using robotic surgery, we're able to kind of still execute that because the robot kind of focuses in this area of interest right here. And this patient did very well. He actually went back to racing motorcycles, but that's not common. So this is also just a little scheme here, just kind of showing, the bone in 3D and how we can fit implants in, with the, total knee system. I don't have a video, but you can get an idea of how you can look at it in all the different views. This picture from my prior practice, so that's me, of course, over there, and that's the robot in the background here. That's the surgical field. But one thing we have to do with the procedure, we have to kind of put these kind of like satellite dishes like onto the extremity so that the robot can communicate with the surgical field. And of course, like we take those out after the surgery. This is a case that both myself and Dr. Bavaro do which is a partial knee replacement. So in terms of candidates, not everyone is a candidate for partial knee replacement. I say about 10 to 15% of knee candidates, but it can be an attractive option, especially if someone is younger. So in this is a right knee AP view. This is the inner part of the knee or the medial aspect. You can see that this joint space is obliterated compared to the contralateral view. And then, but the lateral joint space in the patellofemoral right here is relatively preserved. So he is a good candidate for doing a partial knee replacement. So this is, what we're able to do with the robot, able to precisely, kind of make those bony cuts and place the implants, which is very important for this type of procedure. And this patient also did very well. He went back to surfing in about like 2-3 months. Not everyone's like this, so I don't want to give the impression that they all go to these extreme sports, but the ones that are very well motivated, they find a way. So in summary, we discussed conservative measures for osteoarthritis of the hip and the knee. That includes cortisone and viscosupplementation injections. We also did discuss goals for optimizing potential surgical locations. That includes BMI, hemoglobin, A1C, as well as smoking. We also mentioned some other risk factors such as chronic narcotic use, as well as psychiatric disorder. We also mentioned potential for same-day surgery in some patients, as well as the typical hospital course in which they usually go home on post-operative number 1, as well as post-operative management as well. And then finally, we mentioned a robotic-assisted surgery. So that's something that we'll be getting very soon at St. Barnabas, and we'll be able to offer to our patients. And it's a procedure that both me and Dr. Bavaro do, and we feel it's an emerging technology and basically the future for total joint replacement. So thank you. As a dad of a 7-month-old, I'm very proud to include my 7-month-old daughter. And right here, here's some contact information. I think Dr. Bavaro is on the call as well, but these are our phone numbers and emails. I will be put in the St. Barnabas system by next week, so I should have my email by that point. But you can contact me or text me any problems without any problems. And the other contact I have up here is Sherelle Smallwood. So she's our surgical and scheduling coordinator. So that's someone in which, if we're going to get kind of some referrals to St. Barnabas, either to myself or Dr. Bavaro or some of the other providers. As for, kind of getting into union, we'll have to kind of figure that out once I get credentialed. But thank you very much. And hopefully that any questions.
Any questions, anyone?
Thank you, Dr. Su, for such a wonderful summary of what's out there, and it's very succinct and understandable. It's always good to get like a summary that everybody can understand, and it's provided a lot of information in a very short period of time, and I think that I don't think we kind of knew all the possibilities. And the other thing is, in union, actually, a lot of times we, in urgent care, when there's an injury of the knee, they usually don't get a pelvic view. Would you like that? Because I can tell them to do it.
If it's an injury, usually not. Okay. I mean, I guess it depends on, I think in most cases you wouldn't need to, but if you do see like adolescents, potentially someone with like skiffy, like presents knee pain, and that's something you probably should get like a single view of the pelvis. But I think routinely, say if someone just kind of twisted their knee or hurt it during a sport, and they're pointing to their knee is swollen, usually a knee would be sufficient. But for urgent care, I don't think you necessarily have to change the views that you would get. But that being said, if any of the providers had any questions about x-rays, then they can always kind of like text us. And then, then we can kind of get back to them to see, hopefully right away, to kind of see, what we think.
I want to
add something with that too for urgent care. It's sometimes hard to localize pain in your leg, and we quite often will see
quite often you'll see what? I think you got cut off.
Actually, to range of motion during heat. Oh God, I'm so sorry. Can you hear me? Hello? I'm so
Yes, we
sorry.
can hear you now.
Yeah,
Unfortunately,
I'm
you're breaking
so
up.
You
sorry.
broke up. You
Yeah.
broke up a little bit.
All right. Yeah, the cell service here at the hospital is not the greatest, but in general, patients with injuries to their legs sometimes have a difficult time localizing their pain. And if there's any doubt, you would get a hip X-ray depending on the mechanism. Dr. Su mentioned the younger people, but we've seen
Okay, Dr. Barr, you're cutting out a bit, but I think your point's well taken. You know, if you're not sure, you potentially could get some additional imaging, like a joint above and below. Yeah, if the patient is able to kind of walk in, you know, under their own power, I think most cases would be okay. But it's not a bad idea if you want to add one, add a pelvis or a head.
And a second thing is technical. I'm not sure, the equipment here does weight bearing x-rays. I can double check, but I think they have problems with that. I don't know if you or if they didn't have the right seating or.
Yeah, I have to talk to radiology. I mean,
Yeah.
Naveen mentioned that they were able to get it, so I'll have to kind of see kind of what he did and what limitations are.
And do you mind quickly going through that slide? Because some of our providers got here a little bit late. If you want to, because we can, like we're saying, some of our providers might be able to get these x-rays to you before they come see you, which.
Yeah, I think the best thing, because Naveen, that's what Naveen was suggesting, is maybe we create like an orthopedic set, you know, for like the knee and hip. So let me see over here. But this is basically what I recommend. You know, pelvis, weight bearing, and knee 4Ds. But in some cases where, as I mentioned before, if you are there's some question of it, like with hip pain, it's not a bad idea to get a pelvis and also get a lumbar. And then for a knee, you get the knee 4 views and also get the pelvis as well.
Actually, I guess, I'm sure you're probably gonna, can you provide us with the slides and then we can share it?
Yeah, absolutely. Yeah.
Hi, my name is Lucas. I'm a medical student here with Dr. Reed in the clinic.
Mhm.
So I actually saw a patient who had a knee replacement 2 months ago. And when I asked her if she needed a dental referral, she said she had gone, but they said that until her knees get better and then until the knees like resolve, that she wouldn't be able to get the treatment for that she needed for dental treatment. So I didn't really understand why, like what do your teeth have to do with your knees, but you just elucidated that for us today, and I wanted to thank you for sharing that.
It's a topic that's I would say it's not the most studied because it's a very rare complication that can happen, but it is in fact an avoidable complication. So we usually ask people to defer for the dental work, and that kind of depends on what the provider does. But the other thing, and this is some controversy as well, is that when they get dental work in the future, whether you give them some antibiotics with that dental work. So I actually recommend it, but there's not really good studies involving it.
Yeah, the American Academy of Orthopedic Surgeons and the ADA, the Dental Association, go back and forth. But if a patient is already immunocompromised, they're diabetics, they're smokers, and they have dental work and they already have a prosthesis, that makes sense to pre-medicate them. And that's the takeaway. And then the golden rule is that we try to wait for any surgery, dental surgery, or further elective surgery for about 6 months after their joint replacement. There's a little more protection that our bodies have after 6 months. The other thing is the risk factors. We're kind of sticklers for that. So we really want to make our patients as healthy as possible before the surgery to keep their risk of getting an infection down. That, I joke around that, the dark side of orthopedics are the infected joint replacements, because once they get infected, their lives are forever changed for the worse. It's a multiple surgery. So getting the risk factors that we can modify under control is so important. If we can, and there's studies looking at if they have more than one of these modifiable risk factors, their risk for infection, their risk for other problems is more than double, is exponential. So if it's a smoker, diabetic, their risk for infection, their risk for a blood clot goes really high. Same thing, obesity is smoking. So we really try to insist that the patients get themselves healthy because, the surgery looks magical. We're using robots now, and most of them have had friends who have done well. But when it goes badly, it's a terrible thing. And it's also a huge economic drain on the hospital in addition to the human costs. So, it's so important, getting their BMI down. And I tell patients, look, we'll take care of you. We'll get you through this, but you got to help us. You got to work with us. There's a big operation. This is a big investment in your health that you have to make. Most of the surgeries that we're doing here now are outpatient, and we coach the patients. We make them have arrangements with their family. If they have an elevator building, to maybe stay with someone who doesn't. At the very least, we can change their insurance to Medicaid and get them a home health attendant, so that because we don't want them to stay in the hospital, if at all possible. The risk of infection goes up when they're hospitalized. And likewise, if they go to a short-term rehab, their risk for infection goes up. And most of the insurance companies don't want to pay for short-term rehab for obvious reasons, but also they don't want to pay for the infection. So important to get these patients healthy and to get their family involved and improve their social situation before. None of these are emergency surgeries.
Along those lines about the longevity of the knee and hip replacement, what do the studies show in terms of like how long do they last in general, or do you have to get the double replacement sometimes, or and maybe that it helps when we refer patients, or I know you decide, but talking to the patients about when might be a good time to start considering this.
Sure. Yeah. I mean, I think with the total joint replacement, in general, the patients do very well. I think in the past, we used to tell patients to wait as long as possible, in terms of, putting it off. But, if it's something where, it's really kind of bothering them, we feel that we really can benefit from them, that the kind of the newer materials that we use do last longer. But in terms of how long it lasts, it depends. If there's no problems, what the registry data shows, each year you have a 0.5 to 1% chance of failure. So what that kind of translates to over 20 years, there's a 80-90% chance that it's going to be fine. Of course, if something else happens, you get infected, you get hit by a car, you break the replacement, and of course that's not going to last as long. But I would say in general, if someone's in their 60s, usually if no problem, they'll last the rest of their life. Or, when you get to that age, when you get to like 80 or something like that, you're just not as active. So even if you did have limited mobility, you're not going to, risk like a much bigger surgery to kind of get back on. But I would say, it's best that we kind of discuss that. But yeah, I mean, you can, that's another factor I didn't bring up, which is age, because age is also kind of a non-modifiable risk factor, as far as I know. And some people will say age is a number, but I would say like when you kind of get to that age between 75 and 80, that's kind of when you might have to make some decisions, because you want to, in the end, this is a quality of life issue, so you want to be able to kind of do the things that you want to be able to enjoy. But of course, if you're, you don't know like how your health is going to be over those course of several years. So, it depends. I mean, that being said, there have been patients that I've operated in their 80s that have done well, but you have to have a pretty good discussion with them about the risks and benefits.
And are robotics now becoming more common for a lot of these procedures? I know we're starting it here, but in other institutions?
Yeah, no, absolutely. Yeah, I mean, where I was before, I was with the company Summit Health, and then they were more known in New Jersey, but they were doing New York. But I was operating at Mount Sinai West. A lot of those doctors there use robotics, so like we're getting one robot, but over there they have three, so, that's something, and everyone's different, some people use them for all the procedures, and other people might use them a little bit more selectively. I try to use it for majority of procedures, but in some cases where, because the procedure does take a little bit longer, if some cases where I feel like it's best to just kind of get through the case, and I may not use a robot, so everyone's a little bit different. But I think, it's gone to the point where basically every kind of orthopedic company has their own robot, so it's kind of, is kind of like going to get to the point probably like in which hospital, like which robot are you going to have?
Yeah, and to that end, I started using robotics very early on. I was an early adopter, and I was being made fun of by the other orthopedists. Oh, you need a robot to do this. And this is at Lenox Hill Hospital. One by one, they each tried the robot, and they all have adopted it because it's so precise. And Dr. Stu and I have talked about this, that I just did a knee replacement today, and the results are very good, but you lose that precision, and it's so nice to have it. And what we're hoping that precision turns out to is longevity. Their early studies early on show that patients who are at increased risk for early loosening, young active people, when they're done robotically, their rates of early loosening go dramatically down. So we're hoping that translates later on with studies to increase longevity of the components. So it's very hard once you use it to feel as good about doing a hip or knee replacement without it, because it's just so precise.
And as you know, we are primary care providers. Any tips on avoiding or maintaining knee and hip health from the prevention side that you give your patients?
I mean, I think you want to encourage your patients to be as active as possible. You know, you want them to walk, you want to get outside. You know, you don't want them to, you don't want things to go down a dark path, you know, where they, you know, are taking narcotics and things like that. There's not a lot of, you know, sometimes people ask about like, you know, what activity you should be doing, should be running, for example. That's something that's not well studied, but actually, you know, there is kind of an orthopedic study where they looked at marathon runners, and they actually showed that their, you know, their risk of arthritis was actually much lower than the general population, because cartilage by itself can expand and contract. You know, so when you actually do weight-bearing activity on it, it can be helpful. So I think in general, just kind of some maintenance in terms of keeping your strength and range of motion. That's good in general. In terms of like preventative, there's nothing really that well studied. You know, you can do certain supplements like oral supplements. So I'd say the most common oral supplements would be turmeric, and then the other one is glucosamine with or without chondroitin sulfate. They're not well studied. I'd say that, you know, it's no harm in giving them. You know, some people will take them, and like turmeric, some people cook with turmeric, so you can just kind of throw a little bit more in there. But I think in general is, you know, just try to maintain, you know, just kind of strength and motion. And you try the course of therapy. And if something in which it's just not getting better, you can refer to us and kind of see how they are.
I also think weight loss is so important. I mean, obesity increases your risk for hip and knee arthritis. So if we can get our patients' weight down, especially when they're early on in life, the risk of their hips and knees wearing out later, you know, at an early age in their 50s and some people 40s is really a good service to do. So if we could do prevention, I think that would be the number one thing, would be, you know, maintaining a low body weight. I hate to say lose weight because it's very hard. And patients get mad when they come in. I say, you got to lose weight. I say, no, you got to maintain as low a body weight as possible. That sounds less accusatory. And exercise programs. Nobody wants to walk, but just walking is very helpful. So 2 easy, low-tech things to prevent needing a high-tech surgery.
Thank you. Any other questions?
I have a question. What's the rate of like infection, like after the knee replacement? I mean, what's a realistic rate that you can say to your patients?
Yeah, it varies. Yeah, it depends on the surgeon, depends on the hospital you do it on. You know, they've done thorough studies. I think in some studies they say, because really what we're concerned about is periprosthetic infection. You know, if a patient has like a wound issue like cellulitis, usually you can kind of treat that with a course of antibiotics for 10 to 14 days. But I would say in terms of this deep periprosthetic infection, I'd say it's kind of, you know, you give kind of a high estimate, maybe 2 to 3%. But the thing is that if, you know, you have risk factors, or say if you get an injection within 3 months, that actually doubles. So that's kind of more like 5 to 6%. But that's something where if you do have that complication, it's not a fun process. You know, in the end, we want our patients to do better than what they started out with. And when you get an infection, there's going to be a period where they're going to do a lot worse.
In our patient population, one of the highest risks that we have for infection are patients who are IVDA. Their risk goes through the roof, and there's not a lot of literature, but there's a couple of studies showing that if the patients are rehabbed and off drugs for at least 6 months prior to surgery, their risk for infection doesn't quite go back down to baseline, but because a lot of them will relapse after surgery, but it gives you a better sense. So those are like absolute contraindications. Someone is still actively using IV drugs because of the risk for hematogenous bacteremia. So again, we try and, even if it takes them an extra month or two to get healthy, you get their A1C under control, get them to quit smoking. It really helps them. If we can get them to lose weight, sometimes that can delay the surgery. So the newer weight loss drugs seem to be helpful, but we try to make them as healthy as possible. And I tell the patients how bad it could be if they get infected. So a lot of them will buy in to improving their health prior to surgery. My analogy is like if you're going to take your car across country, you would get the tires checked, the brakes checked, oil changed, windshield wiper fluid. So we would do the same thing with our patients because it is like a big journey to recover from this.
I have one follow-up. I know for IV drug use and sex and smoking, how about alcohol? I have a lot of patients that are chronically functional alcoholics, you want to call them, but they're not going to admit it to you. Does that impact surgery, or I don't know, like you think that your patient has, substance, alcohol use disorder? Does that factor in similar way as?
Well, it's the nutrition status what we see with the alcoholics, right? So a lot of them, they're not eating well. So one of the other things we look at for our patients is their total protein and albumin level. If they're low, we try to get them nutrition and get those levels up because that also has been studied showing that the patient's risk for infection goes up because their immune system is not as protective. So all these things, a whole group of patients that have inflammatory arthritis, there's some of the drugs we stop altogether, some of them we continue. So it is a process, and we really count on our medical colleagues to help our patients and help us, give them as high a success rate as possible. But still, even in the best case scenario, healthy patients that are doing everything, there's still always going to be a risk for infection. We just want to make it as low as possible.
Yeah, I would say, there's obviously medical issues that can happen or be exacerbated with alcohol. That's actually a very good question because it's something where you may not know the exact extent of it. I think that's why it's also important to, when we usually have the patient come in for pre-op, like an H&P, we try to have some family view with them. And then hopefully they'll say, hey, doc, you have a couple minutes and we can kind of go through it. But in addition to kind of medical issues, there's obviously physical issues. If they're going to be at increased risk of falling, say if you have them on the blood thinner, and they fall and have an accident, then that could, be a bad thing as well. In terms of any kind of screening for that, I don't think, at least for me, unfortunately, I don't really have a good one for that. It's just to maybe involve family and get more of an idea and to ask those questions.
Yeah.
Next question. What are your thoughts on PRP injections? Do you do them?
What's that?
PRP,
PRP?
do you do them?
I personally don't do PRP. Dr. Bavaro, do you do PRP in the clinic or no?
I do. I do PRP and stem cell, and I have a private practice, and that's what wealthy people want to spend their money on. But I tell them that the literature is not great. This falls somewhere between snake oil and witchcraft. I said that some patients have good results. The insurance companies don't cover them. There is some studies where you combine PRP with stem cell. There's some studies coming out of some of these more sports-oriented places that you can actually get a more potent level of PRP if you have a patient who's exercising beforehand. Stem cells really aren't allowed to be used in the U.S., but we have pluripotential cells that we can get from either marrow for fat, and the fat is not great in terms of stimulating cartilage or bone. So we take bone marrow, and that seems to be mixing with PRP. Some doctors, again, somewhere between snake oil and witchcraft, have reported good results. It is non-standard treatment. It is something that I think works best in someone who has minimal arthritis. I'm not so sure that it's been proven to be really that effective in other countries where they don't have an FDA and they're allowed to use stem cells. You can fly to Germany. There's an institute in Germany. There's an in Costa Rica, and they're doing it, and they're making. I'm not so sure it really does anything.
Yeah, I would just say, yeah, for osteoarthritis, it's not that well studied. I mean, there are some other uses for it, like tennis elbow, Achilles tendonitis, some kind of sports injuries, but for osteoarthritis by itself, it wouldn't be our first line treatment. And there is kind of the out of pocket, usually about at least $1,000 or more.
Anything else, Corey? Anybody else? All right. Well, thank you so much. We really appreciate it. Thank you.
This is Dr. Sherwin Su. I'd like to thank everyone at Union for coming to this talk on robotics and total joint replacements. It's a very exciting topic, and I hope you guys learned something. And as mentioned, this is a technology that we're going to get at St. Barnabas. So we will be able to, it's very exciting to be able to provide this for the community. Thank you.